Hey, Jim Hoffman here for EMS Office Hours, and this is your Monday Minutes. Today, real quick, this is sort of a quick overview of the cervical spine. I know a lot of times during the EMS Office Hours podcast and some of my fellow bloggers, we talk a lot about C-spine immobilization, the benefits for the patient, the damages to patients, potential damages to patients, and lack of research on the whole spinal immobilization process. But I think what is a good idea to do is to just kind of go over a little bit just to C-spine and kind of let you know what it looks like and what it affects. Now, this might be pretty basic for some of you, but I think it's a good idea, of course, to always kind of review key points like this in EMS, and I think it helps us stay on track when we're evaluating our patients and looking for clues to what's going on with our patients. So let's go ahead and take a quick look here at the skeletal system here. Just take a quick look at the C-spine, how you would see it on a regular patient, of course, if their skin was, all removed. So this is a new little feature here I'm trying to work on. Let's go ahead and take a quick look. Zoom down just so you can get a good look here at what it would look like if you're looking at the patient from behind, imagining them with just their bones. So here are your C1 through C7 right here. Okay, you can see where it starts at the base of the skull down to just by where the shoulders would start. Okay, now you can actually look a little bit. I just want to zoom in a little bit here, just give you a closer look as to what it looks like, bone-wise. Okay, I don't want to go too crazy on the anatomy and physiology of this, what it looks like and all, but just to kind of give you an idea when you're looking at a patient, what looking at, and you're looking from the side view, how the C-spine sort of lines up for the patient. Okay, now what I want to try to do here too, just quickly go over what each vertebrae kind of controls as far as the nervous system goes. So if you've got a patient complaining of numbness or something like that, it might lead you to believe there might be some type of a C-spine injury going on. So let's go ahead and take a look at that real quick. Okay, so here is another little picture here of the C-spine all kind of cut away, just to give you an idea. Now, I'm just going to quickly go over each little vertebrae so you can get an idea. Now, C1, this is the main thing, right? You have a damage here. It's going to affect the head, the scalp, bones, face, the brain, sympathetic nervous system, eyes, and the ears. Okay. C2, you're talking about the eyes, optical nerves, sinuses, your mastoid bones, tongue, forehead, and your heart. C3, more facial stuff going on here, right? But we also are affecting now the lungs when you talk about C3. You might have a patient complaining of maybe they can't take a deep breath or they're feeling they're having a problem breathing. Think about these types of deficiencies when you have a patient that might have potential for a C-spine injury. C4, more facial stuff going on, but again, more lungs. We're talking mucous membranes as well here. Okay, think about these types of injuries with people that might have a C-spine injury. Okay, these types of complaints of numbness or lack of feeling to these areas that we've talked about. Most of it, of course, it's up high, right? Because it's the C-spine, so we're talking more facial stuff. But you do have issues as far as blood supply to the head, the heart, and lungs. So don't blow off the fact that a patient might be having some numbness or lack of feeling to, let's say, their face or their teeth, secondary to a possible C-spine injury, that it might not progress to something more serious like their lungs or their heart. Now, C5, vocal cords. Maybe the patient is having a problem speaking to you. Okay, all little clues. Okay, now these might be more extreme for patients, but there's still clues that you can look at when you're assessing a patient and considering that mechanism of injury that we always talk about. The clues you're looking for might coincide with that potential injury the patient has sustained. C6, we're getting a little bit lower here. Talk about neck muscles, shoulders. And think about, again, the patient's injury. Think about their complaint. And think about how, when you're assessing them, whether or not they have any type of deficits or numbness or tingling, all these types of things. And finally, C7. Okay, thyroid gland, shoulders, elbows. Try to put it all together, guys, okay? Because don't just blow it off as a type of injury where you don't really have to worry because they're not complaining of anything. When you do your assessment, a lot of patients might not have any complaints, but if they start complaining of things like numbness or lack of feeling or pins and needles into these areas, right? Think about that it might potentially be damage to their C-spine, C1 through C7. And now for us, it might not be as important to, let's say, document for sure whether we think it's a C3 versus a C5, right? Because it's sort of similar, and face, this here says face, and then here we have nose and lips, right? It's kind of the same thing. But for us, we can say, and we can document that we have a suspicion that it might be a C-spine injury because of this numbness or lack of feeling to these areas. Okay, so guys, that's pretty much it. Again, nothing too in-depth here. I just want to try to make this a quick little overview and sort of a mini refresher on this one little aspect of anatomy that we deal with commonly in the field. It's a common complaint, common suspected type injury with all the longboarding and collaring that we do, based on injuries that we get. So I think it's a good idea, again, pretty basic, right? But I think it's a good idea to, once in a while, just refresh and review these types of things, just to keep us on track, keep us sharp, and keep us aware. Who knows, maybe tomorrow you'll have a patient that'll complain of something like this, and you'll remember that you just got done sort of refreshing on the C-spine during an EMS office hours Monday minutes. So guys, I hope you can use these Monday minutes. If you have any suggestions for some minutes of your own, be sure to send them over to me. It's jhoffman@ems-safety.com. I'd love to hear your suggestions, and maybe I'll go ahead and create a Monday minutes based on something that you want to know about. All right, guys, as always, Jim Hoffman, EMS Office Hours. Stay